Hello, everybody. This is Lecture 7 of Co-occurring disorders. Again, here with Dr. Greg. For Lecture 7, we're going to be covering the various aspects of treatment planning as well as determining the proper level of care for a client. We got the Atkins readings up here as well as an additional reading from Aguera et al. So, jumping right into it, we're going to talk about the important aspects of developing and designing a treatment plan. The first place you're going to start with is going back to the assessment and looking over the problems and needs list, which is oftentimes what we want to think of as the glue between the assessment and treatment plan. All those things that you and your client talked about initially, the main areas of difficulty they're having in their life, we want to make this the core of how we develop their goals. And what goals are just very broad visions of what somebody wants in their future to just make their lives better overall. We want to place goals somewhere out maybe a year from now or so. So this is a long-term endeavor that they're looking for to get out of life, which really our goal doesn't have to necessarily be the main focus of treatment. It's going to be all those little pieces, all those parts to getting to that goal. And that's the most important part about attaining a goal, is that you break this goal down into smaller, more attainable parts to eventually reach your overall goal. And what we call those small steps along the way are objectives. Objectives are meant to be much more specific, observable, measurable, and directly attainable within an explicit amount of time. Of course, when we talk about psychological and mental health issues, that's a lot harder to always be able to guarantee that a goal will be met by a certain time or date. But overall, we can make them more measurable and agreeable. We want these to be things that are realistic, attainable, and also something that the client also desires on some level or another. What's important in doing this and creating a treatment plan of this form, which is going to be basically made up of goals and objectives, as its primary body of a document, is that we want to make sure that we continue to follow up with this as well, with additional periodic reviews, assessment updates, and using screening tools if we feel that that would really help increase the specificity of a client's progress. All in all together, we want to just make sure that the client has a good understanding of what we're doing, how we're doing it, why we're going to do it, and what order that we're going to try and focus on the areas of importance. Now, creating a treatment plan doesn't mean that you're going to follow it word for word every single session. New things are going to inevitably come up, and you're going to find yourself dealing with things differently every day. And so assessment updates functionally are going to be happening regularly, that you're always going to be readjusting your plan and approach, given people's lives are unpredictable, and you'll just have to be ready to change things along the way. Now, some places are going to make you go back and actually change the treatment plan, or other places are going to just say, hey, get to it when you get a chance, but continue to go where your client brings you. Of course, a good question to always ask is, remember the difference between a goal and objective. Goals being more broad, branched out maybe a year from now, or objectives should be within 1 to 3 months of something that they can attain. One thing I want to talk about in particular is the ASAM, which is an assessment tool that's specifically designed to help link areas of greatest need to specific levels of care. The ASAM stands for American Society of Addictive Medicine. It's structured to help with particularly co-occurring disorders, especially if we have a mental health disorder, a substance use disorder, and or a medical disorder of some point. The ASAM is really just a structured approach to being able to look at all the different primary components of an individual and help figure out what resources are really going to apply best to their particular situation. Here's the 6 primary dimensions that the ASAM uses. I'm going to run through these all specifically in the next few slides. They include intoxication and withdrawal, biomedical conditions, emotional, behavior, and cognitive conditions, which I would just call number 3, the mental health dimension. Number 4 is readiness to change, which has a lot to do with the stage of change your client's in. And relapse, continued use, or continued problem potential, which I just call the relapse or triggers dimension. And then recovery and living environment, which is very broad. Here we'll go into the more specifics of these. Well, first off, intoxication and withdrawal, we're assessing exactly to what extent your client is experiencing symptoms of intoxication or withdrawal. So, of most important is how long have they been using? When was the last time they used? How long has it been since they used last if they are currently abstinent? All these are important questions in determining whether or not somebody would maybe currently intoxicated, maybe entering some symptoms of withdrawal, whether they're in active withdrawal or whether they have already gone through the withdrawal stage and are now currently just seeking relapse prevention. So this is one of the more critical dimensions for somebody who may have a substance use disorder. We're going to keep in mind this is where you'll be observing signs of withdrawal from the individual, or you'll be hearing them report symptoms of withdrawal. We want to also know if they're not currently in withdrawal, what their history of withdrawal has been like in the past and what symptoms they've experienced, if they know what they've experienced, as well as um, any sort of interactions with medical conditions they may have. That's the point I really want to make very clear here is that one thing that's very important about these 6 dimensions of the ASAM is looking at how they interact. I'm going to talk more about that a little bit later. We want to also see that we are able to help them manage withdrawals, whatever symptoms they may be experiencing if we need to, which means having proper referrals available to send them to places where they can get the resources they need. Um, One of the main things that's going to interact with intoxication withdrawal are the medical or health hazards, especially if they have a history of seizures, especially if they've had epilepsy in their past. We want to be very careful with somebody who may be having a alcohol use disorder because of the risk of additional seizures. I want to help them also engage in maintaining abstinence, and doing it in a very safe way. If they're using a lot of a substance, we don't want to tell them to just go cold turkey right away. If there's a risk of withdrawals, we want them to gradually reduce so that's not so intense or dangerous. Another important thing to think about, of course, always in promoting patient dignity and their long-term welfare, is what's the difference between withdrawal management and detox? Well, detox is what the human body does. We don't provide that service. That's something that they do. What things like detox centers do is help with withdrawal management. So we help manage the symptoms of withdrawal while the body is detoxing. So just the important distinction there to keep in mind. Dimension 2 are the biomedical conditions, or just medical conditions. We want to get a history of all the different types of diseases or injuries, sources of chronic pain, or physical limitations the individual may have currently or have gone through in the recent past. A couple of particular things you may notice or hear are diabetes, blood pressure, gastric issues like ulcers, autoimmune disorders, broken bones, infections, arthritis, DDD, which stands for degenerative disc disorder, and COPD, which stands for chronic obstructive pulmonary disease. We also want to know if they've had any major head injuries in their past, if they are currently pregnant, or suffering any other forms of disabilities. We want to know the history. We want to know if there's been any flare-ups of these disorders in the past. We want to know if they've had effective forms of treatment in the past. And we want to know, especially, how or if the disorders may be in any way related to their substance use disorder. A very clear example would be somebody who has hepatitis or a liver or cirrhosis of the liver. That liver damage may be very likely in part to do with whether or not they have an existing alcohol use disorder. There's a lot of other ways that biomedical conditions can interact with a substance use disorder. Sometimes a substance use disorder can cover up the symptoms of a medical condition. For instance, opioids. Numbing pain chronically is a very easy way to hide or mask a medical condition such as ulcers. If you are using opioids, you're likely not going to experience the pain or nausea frequently enough. In fact, you may actually be using those drugs partially because of all the pain that you're in from the possible ulcers you may be experiencing. So think a lot about that, how these things can interact as well. Now, of most importance in this particular area is we have to consider whether or not any immediate medical services are necessary. For instance, if the person has recently broken a bone or has any open wounds or major injuries, or is in some form of potential organ failure, such as the liver or pancreas, which can also be very severely affected by chronic alcohol use. Section 3 is emotional, behavioral, and cognitive, or the mental health section. Once again, we want to get a full history of any potential diagnoses they've experienced in the past. We want to know what kind of treatment they've gone through, if they have gone through any treatment, and we especially want to know what's helped. What have they found to help their symptoms? If they have gone through remission from any potential mental health disorder, what do they remember working at that time? And what may they find to be of most help today? I want to be particularly looking for things like trauma, PTSD, other psychiatric illnesses, or neurodevelopmental disorders. Um, of most importance, and you're going to find that each one of these sections are going to have things also we have to highlight as immediate risk that we're going to increase the severity of this dimension. Of course, for the mental health area, that's going to be danger to self or others, whether they're reporting any sort of suicidal or homicidal thoughts or plans. That's going to immediately increase the risk of this dimension. Of course, we also want to think about the positives for some of these dimensions too, the individual strengths. Perhaps they have spiritual connections, a strong sense of hope or purpose in life. Maybe there's other internal resources they have, like assertiveness skills, or just a very calm or friendly sense of humor, something like that. We want to also include things like that in these dimensions. Section 4, readiness to change. Really, we're thinking especially about what stage of change they're in. We talked about the stages of change, I think, in either lecture 1 or 2. I want to examine their confidence about change, their readiness, what motives they have for engaging in change right now, because that's what we're really here for, right? We're here to help change. We can also validate and appraise them for the things that they are currently doing well, but we always want to help guide them to what else they may be working on or maybe avoiding working on. Of most importance too when we're examining their source of motivation is we want to determine whether or not this source of motivation is intrinsic or extrinsic. So is this an external thing like probation that's coercing this person to go into treatment? There's an internal, just a sense of desire to be free of the substance that's making them do this. It's really important to examine this section because that's going to help us determine the best therapeutic approach for whatever phase of treatment they may be in. Another important thing to keep in mind is how this particular stage can clash with the needs of other dimensions, particularly if somebody doesn't feel ready or willing yet to engage in a certain level of services, especially if they're actively using and maybe showing signs and a high risk of withdrawal symptoms. Well, if they're not motivated to go into a detox and residential center, then we're going to have to deal with that some way or another. So really important to keep in mind that you're not going to be able to get someone to successfully go to detox and residential if they're not in the right stage of change. So making the right recommendation means that we're sometimes going to have to make a compromise between what we see being most important for the client and what they see, purely because we have to recognize the importance of having a strong alliance with our client before they're going to agree to do anything. Number 5 is the relapse or continuing use of problem potential. So in this section, we're examining triggers, which is anything that is a visceral reminder of using substances in the past. Some triggers are going to be more obvious than others. For instance, a crack pipe would be a very strong trigger for somebody who had used crack cocaine in the past. But other triggers can be more subtle, things that you may not even think about, which is like going out mowing the lawn in the summer. It could be a trigger for someone because maybe they had been drinking or had a can of beer with them every time they went out to mow the lawn. We can't expect the client to know all of the different types of triggers they may be dealing with. This will be a bit of a trial and error process along the way, which is why sometimes lapses or relapses are an expected part of really fully understanding the extent to which somebody is struggling. We want to know how intense their cravings can be. Different people are going to have different severity of cravings. Some people may not report having cravings at all and yet still lapse back into use because maybe there's a more intellectual reason they think they're using. We want to know whether or not, or we want to know the history, especially. How long relapses have been in the past? How long have stages of abstinence been in the past if they've gotten a good amount of abstinence before? Have they participated in treatment in the past? What's the longest amount of time they've gone sober and what really helped them do that? All very good kind of positive questions to ask in this one too. We want to also look at recovery and living environment. That's dimension 6, and this is a very broad dimension which covers a whole lot of external factors, resources, and barriers, so good and bad things. A variety of different themes can include family or social supports, whether or not they're employed and how well they like their employment. Do they have all the necessary home utilities to live safely and comfortably? Do you have transportation to get to sessions and everything else they need to do throughout the day? What are they doing financially? What kind of sources of debt may they still have that may be hanging over them that you might want to refer them to some financial advisors for? Do they have a gym membership? That can be a really big part of this, that they're able to take care of themselves physically. Plus, that can be a great alternative to drug use. Do they have a church they go to? Do they attend 12-step meetings? Do they have health insurance? That's a really big piece of this. Some agencies you'll work at, maybe they don't have you do any billing, but the resource, the financial part is going to be a factor one way or another, whether we talk about it or not. Do they have a psychiatrist that they've been referred to as helping with their mental health part? And of course, on the flip side, the barriers are unemployment, court fees or probation, homelessness, family conflict, divorce, enablers or dealers, and a whole variety of other things that can get in the way too. So that's the 6 different dimensions: recovery, living environment, relapse, readiness to change, mental health, medical health, intoxication, and withdrawal. Once you go through all these dimensions, well, first and foremost, you're going to set a risk level for each of these. And the risk level goes from 0 to 4. This requires just a good amount of clinical interpretation as to the particular details you hear. Obviously, some of those higher risk factors are going to be more important than others. For instance, living in a dangerous environment where they are homeless and living on the streets, that would be a much higher indicator. That could put somebody at the serious or utmost severity, depending on where they live. Is this the winter, right? This could be a risk of their own wellness and their own safety. So that's where you're going to see a 3 or 4 at, is when it's a real risk to their safety somehow. And each one of these dimensions could have factors involved that could make it that intense. Once you've rated each dimension 0 to 4, you want to examine them all, how they may interact. Those interactions are so important to be able to determine. I mentioned a few interactions that can happen as you go through these dimensions, but make sure to examine those, especially for the treatment plan paper we'll be doing. Also, make sure that you're doing level of care that's based on the client's readiness and areas of greatest risk. So once you've kind of put all these dimensions together, you've looked at the ones that are of greatest risk, and you've also assessed what the client is interested in, you have to decide an overall level of care that you're going to recommend for this particular client. And that's what we're going to get into on the next slide. I'm going to cut the clip off right now and start up on section 2 before we go into particular levels of care.